to my channel. I hope you all are good, safe and blessed abundantly. Thank you so much for stopping by. I hope that you will really enjoy this video, or you are enjoying my channel. I really hope so. Thank you so much for engaging. Thank you for watching this video and also liking. I kindly ask that you share this video to everyone, actually, because this is a very important video. And yeah, for those who are new buddies, thank you so much also for coming by and stopping by. I really hope that you will be part of the buddies family. Kindly hit the subscribe button and join this amazing channel. It is fun, it is good, it is everything and more, and we learn in this channel. Hey, today is a learning video and I really hope that you will enjoy it. I will be speaking about HIV medications or drugs. You'll see me referring to drugs sometimes. I want this video to be really short, so I will just speak about the common drugs in South Africa that we are using, that you will mostly find in the healthcare facilities. Yeah, so let us get straight into this video. Alright buddies, so firstly I'm gonna start with first line drugs. Please note that there is first line, second line and third line drugs. It is all dependent on the viral load. Yeah, so these drugs is actually NRTIs, which means nucleoside / nucleotide reverse transcriptase inhibitors, right? So TDF is also number one drug. TDF is tenofovir disoproxil fumarate. It is prescribed to patients with a weight of 30 and above and 10 years and above. Please note that I said and, not or. It has to go in conjunction, right? And TDF is also helpful with 3TC when the patient has hepatitis B, right? If the hepatitis B is positive, right? So if I may put it in simple terms, it has a way of fixing it. So whether the patient is on second line or third line and they are on second line, am I making sense? Yeah, they are not on first line, they're on second line. TDF also needs to be part of those drugs, right? So as you will see, we all have 3 drugs. It's either 2 NRTIs and 1 NRTIs, right? Yes, so that is it with a TDF. TDF side effects is nausea, vomiting, itchiness and a rash, which should resolve actually in a day or 2, or actually the maximum 2 weeks or a week, right? That is why when most patients start on ARVs, they will complain of side effects. It is normal, completely normal, but it should go away in few days time, right? Yeah, so that is it with TDF. We're moving now to FTC, which is emtricitabine, right? So it is also part of the NRTI drugs, which when you there's a combination FTC and 3TC is called tenamine, right? Yeah, so those the side effects for FTC can be your diarrhea, can be your tiredness, nausea, vomiting. As I said, also it should go away in no time, right? Or in a few days time, right? Then mostly it is definitely in your first line, which in the past, okay, let me say not in the past, but in the beginning we used to they used to use atroiza, right, which was TDF, FTC and efavirenz, right? Yeah, so yeah, FTC is 200 milligram and TDF is 300 milligram, right? And then now we're moving to 3TC, right? 3TC is lamivudine, and this drug is very important, or you must monitor it when the patient has a renal dysfunction, right? I'll put up a what is this thing, a picture of the app that I use that guides you to say if this EGFR is like more than 60, then obviously the normal dose is 300 milligram 300 milligram daily, right? Or it's 150 milligram 12 hourly, right? But if your EGFR is like 10 to 15, then the milligram is 150 milligram daily, right? I almost said 150 milligram per hour daily. But in any case, yeah, so your 3TC plays a role, actually a big role in the actually correcting your renal function. Yeah, and if the EGFR is less than 10, then the patient must be on 50 milligram daily, which is now a syrup, right? Yes, so if TDF and 3TC, do we have a combination for that? No, we don't. TDF and 3TC, no, we don't. No, we don't, but I was just getting lost there. But in any case, yes, that is it with a 3TC. I did mention the side effects. Now we move on to efavirenz, right, or EFV. This drug is currently being phased out in South Africa because of its side effects, right? So one of the side effects was hallucinations, bad dreams, confusion, gynecomastia, and chest pains, right? So those are some side effects that it had on patients. And if you remember, or I don't know if you have been consulting patients, when they started treatment, like 2014 or that side, they used to have like hallucinations or having bad dreams, so that was quite bad to patients, and it would actually discourage them on being on ARVs, because like if I am having hallucinations, I can just imagine, and I still need to drink this pill every day. Like, so yeah, it's currently phasing out, and which is being replaced by DTG, which is dolutegravir. Dolutegravir is part of the INSTI drugs, which is I'll remember it now, buddies, but I'll just put it down what it actually is, like the class of it. So dolutegravir is a drug that was invented or was introduced to us in 2019. Let me speak about a dolutegravir, right, which is currently phasing out or replacing efavirenz, right? One of the greatest reasons why it's there, it is because it has a superior efficacy and a faster rate of viral load suppression. Literally, this drug can reduce the viral load to lower than detected in a month. So that's how fast it is, and that's how excited we are to have this drug. And it has high genetic barrier to resistance, so it's not so easy to be resistant to this drug, which is very much exciting. Yeah. And also it has no interactions or drug interactions with contraceptives. It's also well tolerated, so it is generally a good drug, and we're happy about it. One of the side effects can include your nausea, your vomiting, and also weight gain, which I have been seeing in some patients. So definitely your these patients will not be eligible for this, because they could develop cholesterol, or patients who are currently on cholesterol medication is not really advisable, even though there is no set guideline that says don't give dolutegravir if the patient has cholesterol, right? So yeah, but the thing is, it has drug interactions with other medication like rifampicin, right? So if your patient is on TB medication and they are on TLD basically is tenofovir, 3-TC, and dolutegravir, right? That is the first line drugs. In fact, now the new guideline says it's TLD1. TLD1 basically means that patients who were never on ARVs, like they are ART naive, when you initiate them, it's going to be TLD1, right? And TLD2 is patients who has an experience or who have had ARVs before, right? So they failed second line. Now we are coming back to TLD2, right? Simply means they exposed to ARVs, right? So yeah, if the patient is on rifampicin, TB medication, they need to be boosted with an additional dolutegravir, which is 50 milligrams. So the patient will be on TLD and DTG 50 milligram after meals, right? So yeah, and also dolutegravir has an interaction with iron supplements, multivitamins, and antacids, right? When it comes to the antacids, you need to drink it actually either 6 hours before or 2 hours after, right? So you will just work out for yourself. It depends when is the patient drinking the medication, right? So also a DTG and calcium needs to be taken together with food, right? If it's taken without food, then there's not going to be a good absorption of the DTG. Then that means, well, I was explaining to my patients, it means you didn't drink medication, so obviously there's not going to be any viral load suppression, you know. So yeah, right. What else? Yeah. So I'll just also put like a poster of how actually like the drug interactions is a DTG. And also when it comes to metformin, the patient must not be on DTG if they are on the highest dose of metformin and they're also drinking it 3 times a day, right? So if they're on 800 milligram TDS, which is 3 times a day, it's a no-go zone. The patient must not be on DTG. And also please note, guys, when I say replacing efavirenz, it doesn't mean that efavirenz will like no longer be there, because we technically still need efavirenz for, you know, those first line patients that cannot be on DTG, like as I have mentioned, right? Sorry about that. So yeah, that is it with dolutegravir. Yeah, comment down below if you do have any questions. I will definitely respond to that. And then one in NRTI that I forgot is AZT, which is zidovudine. You know, but I always get confused, ne? In my mind, ne, AZT should be azithromycin. Like, it just makes sense. But like zidovudine, but in any case, buddies, AZT is 300 milligram, right? And it is actually part of your second line, right? So second line drugs include your ABC, which is abacavir, and AZT, which is zidovudine, right? So yeah, so this drug has side effects like hepatotoxicity, myopathy, confusion, your nausea, and most importantly, or why we try to avoid it, is if the patient has anemia, or because it has what will I say, it can exacerbate anemia, or it can cause anemia, right? So yeah, that is it when it comes to AZT. So literally your second line is, it's gonna be your AZT, 3-TC, and DTG, right? dolutegravir, or in the past they used to include efavirenz, right? Or they used to include lopinavir, which we're still going to talk about it. It's part of the protease inhibitor class, right? Yeah. What I wanted to say something about the second line. Oh, okay. Since we are on second line, now we're gonna move to abacavir, which is your ABC, which we mostly use for patients with a renal yeah, it's actually a renal friendly regimen, right? We call it a renal friendly regimen, which is your ABC, 3TC, and DTG, right? Or it can be lopinavir, but mostly we want now patients to be in a DTG based regimen, right? When it comes to AZT, I forgot to say, I don't know if I mentioned it wrong, but AZT is actually 300 milligram twice daily, which is 12 hourly, right? So there's a combination of AZT and 3TC, which is called Zovula, right? And that is it's actually twice daily. So we normally recommend that patients, so let's say the patient is in AZT, 3TC, and DTG, right? So that means all in all they will drink 3 drugs, right? So which is there's gonna be 2 bottles, because this one is combined. Again, this is Zovula, right? Or like there's different brands to this, but it's gonna be AZT and 3TC. So if the patient decides to drink their medication at 8 o'clock at night, so because it's 12 hourly, it must be 8 o'clock in the morning and 8 o'clock at night, right? If it's 6 o'clock in the morning, it must be 6 o'clock at night. So it's 12 hourly, right? And then this DTG is obviously, it depends on the patient, right? Either if let's say the patient is drinking the medication at 8 o'clock, so either they're gonna drink 1 medication or this AZT and 3TC at 8 in the morning, and at night now drink 2, which is AZT, 3TC, and DTG, right? So yeah, it just depends what the patient wants. So I just wanted to highlight that because I think I have forgotten it. Now when it comes to ABC also is part of the second line drugs, and it is actually a renal friendly regimen, which is either 300 milligram twice daily, or 12 hourly, or 600 milligram daily, right? Once a day. So ABC and 3TC is called Dumiva. So a patient can be on ABC, 3TC, and dolutegravir, or ABC, 3TC, and lopinavir, right? Or efavirenz. These are just the drugs that the patient may be in, right? So yeah, so what we mostly strive for, and what is I think mostly important in HIV, is to simplify the drugs, guys. Like if the patient is no longer actually don't qualify for first line is only 1 pill. I think you guys know that it's 3 ingredients into 1, right? Which we call the TEE, which is tenofovir, FTC, and efavirenz, right? Or TLD, 3TC, if 3TC, TDF, and dolutegravir, which is DTG. Yeah, so yeah, just simplify the drugs, guys. If the patient is on ABC, it becomes better now, because like now there is a combination Ageria Dumiva, which is ABC and 3TC, and then now dolutegravir, right? So basically, if the patient decides to drink their medication at 8 o'clock at night, they can drink only 2 medication once, right? Then this separating of times, it's actually not nice to the patient, and it's also not efficient, but it's like it's not convenient, because now in this drink in the morning, it's just a lot. But yeah, so a side effect of ABC is actually hypersensitivity to ABC. Now I will list actually what is it, because it includes your rash, it includes your like generalized rash, it includes your fever. I'll just write it down actually. So yeah, but that is it when it comes to the first line and second line drugs. Yeah, so please note that the NNRTIs is your efavirenz, which it was actually in the first line drug, and efavirenz and nevirapine. Nevirapine is used in kids. Yeah, and I will also link a picture of actually Uguti. If the child is from this age to this age, then they need to be on this regimen, right? Yeah, so that it will just be easier, buddies. And also so that you can revert back into this video. But also, buddies, you know the new guidelines you can download anyway, but the app actually, which I'll again link somewhere here or whatever, is very important. But it's because like it's very easy. It tells you the doses, it tells you the doses, it tells you the abbreviations, it tells you side effects, adult dose, pediatric dose. There's just a lot. You learn around, just play around with the app, you will see. That is actually the now for the healthcare workers, right? Last drugs that I'm going to be speaking about is your protease inhibitors, which is your lopinavir boosted with ritonavir and darunavir and atazanavir, which is ATV, and darunavir is DRV, right? Which these are actually, lopinavir is actually part of your second line, right? Yeah, definitely part of your second line. I have not experienced it in third line. I haven't, but I'm not saying they should be. I'll tell you why, right? So let's talk about lopinavir. Lopinavir doesn't go alone. It always needs to be boosted with ritonavir, right? For the dosages, please go to that app. It actually shows you the dosages. I think it's 400 and 100/100 milligram, the standard dose, right? One of the side effects can be diarrhea. Patients get diarrhea a lot. So the thing is, we're just gonna treat diarrhea. If it continues, then there's something underlying there, right? And also it messes actually with your metabolic disorders. Well, it causes metabolic disorders. So please also, when you do your annual bloods, check your cholesterol in your patients, and also in kids actually. Let us check the triglycerides, right? Yeah, so that we monitor it if it's fine or not. And also lopinavir is also used in kids, which we call it caletra, right? It's a very bitter, really bitter, but in now currently, right, there is disperable for DTG, right, which is so much better because it is nicer than Caletra, and it also has a strawberry taste, so that's better. Now kids will not vomit it, because a lot of kids, they are unsuppressed because of this, they vomit after drinking their medication. So but what you can do for now, if this disperable are not, the DTG disperable are not in your facility, the child can firstly drink the ABC and a 3TC, and then drink the Caletra later on. Not later on, but like last, and then and then after, just immediately then Danon, or you can give them sweets or something that they like, right? Or you can actually also mix it with food, like solid food, but not high quantity, obviously. But yeah, so that's what you can do in order for them not to vomit it out, or not to like tasted, right? So yeah, when it comes, let's speak about third line, right? Third line, you don't just prescribe it for yourself and say, you failed second line, let me prescribe you third line. No, there's a protocol that we need to get to, right? Firstly, we need to do a resistance test, right? And there's a whole papers that you need to fill in. It's like a form. It asks you the viral load, the previous viral load, the HBs, if the patient had TB. There's just a lot, right? And you send it to TCLAT, right? They are the ones. Okay, firstly, no, I'm wrong. Wait, you send the resistance test, right? And then if that the resistance test is done via the lab, right? If that resistant test, it comes and say the patient mostly is resistant to each and every drug, right? Or most of the drug, right? Then we need to apply for third line, right? The experts, they will now see who's okay, or resistance to this, susceptible to this. Let us make their own, like a what is this thing, tailor-made medication. So basically third line is tailor-made, let's put it that way, right? Which you will see your darunavir will be there sometimes, or your atazanavir will be there. Yeah, also ATV actually can form part of your second line, right? So yeah, that is it when it comes to third line. But is you don't just prescribe third line in J because you like the experts needs to you need to apply for it, and it will come back after maybe like 6 weeks or thing. So don't delay actually applying for the patient, right? I think that is it, buddies, from me. I hope that you really enjoyed this video. Comment down below if you have any questions. Please share this video. I feel like it's very important to everyone, most importantly when it comes to the patients who are on ARVs. Please know your medication, guys. Please know that you are on TLD or you are on second line, actually which second line you are at, because number one, files can get lost, system can crash. There's just a lot that can happen. But if you know, maybe you're actually moving to another province, you tell them, oh Mina, I'm on TLD, or I'm on TEE, or I'm on renal friendly. And also know the dosages. If you can, please know the dosages. In fact, today I was with a patient who needed hypertension medication, right? So now the system tier does not show that. They don't show like the milligrams, right? And the patient is couldn't also remember what drugs they're on. Luckily, I had, like, in the consultation room there was empty boxes of hypertension medication. Then she was like, oh, it's this one and this one and this one. So we just figured it out. But then I told her that she must bring her medication the next time she comes. So yeah, it's just important to know the dosages that you are on, so that it will be easier for you. So yeah, thank you so much. I'll see you on the next video. Bye.